Welcome back to the Paindora Podcast. I am your co-host, Melissa Cady, the Challenge Doctor, with my co-host, Dr. Kevin Cuccaro, known as Dr. Kevin. And we're here to... You got to come up with another name, you know? If I'm going to have all these descriptors on myself, you got to lengthen up yours a little bit.
Let me think.
We're going to work on that for the next show. We're here going to talk about just something simple because it can get quite complicated. We might have a few opinions on this, but many times people reference doctor for various types of fields. And the question is, what does doctor mean to people? And, how sometimes people use that word maybe when it's not appropriate.
Yeah, that's a very interesting topic of conversation, and particularly in this day of the internet, right? Because the internet has allowed everybody to expand their reach dramatically. You can set up a small platform like we're really doing, where you set up really quite easily. You have your own almost radio or TV show, you can consider it, that you can publish, and then based on how you promote that or get people interested, or who you, in some situations, I wouldn't necessarily say this is the best way, but who you cater to, like just say, well, people want to hear this, so I'm just going to make up stuff around this. It's provided people opportunity to very leverage and get attention. And, as both of us have kind of been in this internet space, then kind of the new Wild West world, you see a lot of this stuff, and particularly when you're looking at health. It is amazing to see so much health advice and information that's being dispensed out there by doctors. Facebook has things, YouTube has ads for blah, blah, doctor so-and-so says this, or doctor so-and-so says this. And for me, and I'm sure for you, being a physician, then you go, well, okay, what's their background? What's their specialty? And the first couple of times you're like, wait, what? You're calling yourself a doctor? And I don't want to necessarily say they are misleading people, but the fact of the matter is, doctor doesn't mean, like, in the way that if you're saying something about health and you're using the word doctor associated with it, then the assumption is that you have some healthcare related facility, and most commonly that you have either gone to medical school or something like that. And in the online space, that's just not the case. And what I want for listeners and watchers to be aware of, this is not to say that the information is bad per se, but you have to look at both what the information is, the quality of the information, how, what the research, the statistics, are they familiar with the research and statistics behind that information? And lastly, what is their background that provides some degree of credibility? Now, and again, there's people who don't have, say, they are not physicians or whatever, and have some really, really great knowledge and can do amazing things. But you have to kind of weed through their information over and over before you get to that point where you can trust them. But there's a lot of people out there who have these weird degrees that are saying they're doctor of something and giving you health advice. And for me personally, if I can't figure out what your background is, preferably on the first page of you telling me that you're a doctor, I have big problems with that. And there are people out there advertising this stuff that has taken me 2, 3, or 5 Google searches to simply find out what they are a doctor of. In one case, there was a doctor of mythology. And that's great. I mean, mythology is pretty cool. I read it a lot when I was young, but I don't think that necessarily correlates with saying you're a doctor of some healthcare related topic. Another one was another clinical background I won't get into, but very, very misleading. And so it's kind of incumbent on the individual now to, if you hear the word doctor, unfortunately, you can't leave it at that. You have to go a doctor of what, and then do the next steps to kind of figure that out. And again, that doesn't necessarily mean the information is bad or wrong or not useful, but it should be a warning sign if someone's not proud enough or at least confident enough in their clinical background to label it as such.
Right. Well, it makes me think of, I actually found this on LinkedIn. So as an anesthesiologist, now there are anesthesiologists that are in like the UK or in Australia. They're called anesthetists, or anesthetists, but they are not called nurse anesthetists. But what's interesting is anesthesiologists is usually inferring, if you look up definitions, if someone sees something different, I'd love to see it. But you've gone through medical school 4 years and at least a minimum of 4 years of postgraduate training, which usually includes 1 year of internship and 3 years of anesthesiology training, sometimes some other subspecialty afterwards. But anesthesiologist this, but what I found on LinkedIn was someone who wrote nurse anesthesiologist. And I think to myself, okay, it's relating to you being a physician, and the psychology behind that I find fascinating, because we all want to feel more important sometimes than we are, or at least feel like we are respected for the level of training that we've had. So for what I see, just be proud of who you are. You made a choice. You made a choice to become either a nurse anesthetist or an anesthesiologist assistant or an anesthesiologist. And there's no reason you can't just state it. Like you said, you shouldn't have to go through 5 levels of information to figure out what you are. And I've seen plenty of situations in the anesthesia world too, where the nurse will say, I'm Dr. So-and-so, but they have a doctorate of something else. And it's very clear, and at least to me, for patients, they're not looking at the different levels of nursing degrees. They are basically thinking you are a physician. Now, like you said, it doesn't mean that they are less clinically capable of taking care of you. But if you're trying to give an impression to a patient as to what you are, if you say you're a Dr. So-and-so, I'm your nurse anesthetist who has a doctorate in psychology, boom, one quick explanation. So at least they know who they're dealing with. I think that's important. And before I forget, PhD can mean you can use doctor in front of, but like you said, if it's on a website, they should say what it is. But people could probably say back in the day, people see DO, we both have DOs, and they may think, oh, are you a doctor? I mean, I've had people think I'm an optometrist, and I'm like, no, that's OD. But the reality is that an MD back in the 1890s didn't like the kind of bloodletting and other things that were going on in the medical system, which is ironic to the things that we're talking about with the pandemic, but decided to basically 4 tenets of basically the body self-healing. You can go through all these different things, but trying to be less invasive and less risky with how they're approaching health. And so that was a branch that came off of an MD. So the first DO was an MD. And over the course of the next 50 years, because of medical education in the military, they were merged into traditional medicine, and hence MDs and DOs are equivalent in this country. But it gets even more complicated when you look at the fact that there are surgeons that are podiatrists that are not MDs or DOs, they're DPMs. There's doctors of podiatry or podiatric medicine. So it can get really complicated, but you just need to know what makes them a doctor. What is their qualification for that title? So that was a lot.
No, I would agree. And really the differential comes down is what is the context that you're using the word in? Because you're not going to find a PhD in philosophy entering a hospital and someone says, we need a Dr. Stat, and says, well, I'm here. I mean, maybe there's a couple, and I know there's a couple people get all bumped in a rug or whatever, but realistically, there's a context around. And I do think, particularly in a healthcare setting, there is misinformation. I don't want this to turn into some nurse anesthetist anesthesiology thing in any way, shape, or form. But that is a new push from them to call themselves nurse anesthesiologists. Then you go, well, why are you doing that?
Yeah.
if you're just like you said, if you're so proud of your career pathway, then be proud in your career. There's some fantastic nurse anesthetists out
Yeah.
there.
And there's some
But
anesthesiologists who wouldn't let them touch me.
I completely agree, but at least you want to be able to firmly define between the two. And the same thing with the DO. I'm doing it more simply because I'm trying to make things easy to understand, but I get uncomfortable when I just say Dr. Kevin Cuccaro, because I want people to know that I'm a DO. I don't want there to be any sort of suspicion that I'm trying to hide something. I'm a DO. That's my background. I'm proud of my background. There are a lot of different reasons for that. Is it different than an MD? I don't know. But it's who I am. I'm not an MD. And and if I get on these things, invited to a course or a seminar, and they'll list something, and it's super common, they'll screw it up and put MD after.
Yeah.
And I'm always like,
same for me.
It's a DO. I am a DO. I am
Yep.
a DO. And I just would like to see that a little bit more often, and particularly, and again, around these complex healthcare topics, just be transparent.
Yeah.
Transparent what your background is, what your experience is, and then if you've got a PhD in mythology or whatever, that's fine. But at least then you can say, I had a PhD in philosophy or in mythology. I'm a doctor of mythology, and this is what it relates to whatever it is that we're doing, rather than us making people assume that you have an MD or a DO in some sort of health related field.
Mm-hmm.
Yeah, it's interesting because you're talking about just in the hospital, which is not even, the online space is like the absolute wild west, because you have people who are going to these, who call themselves doctor, who went to basically those what do they call them, diploma mills, the online schools that you pay a certain fee and then they just give you something, and you have to be able to distinguish those from the people who have the PhDs in the mythology, from the people who have the doctorate in whatever. But in a hospital setting, you see that with a lot of ancillary staff who will label themselves doctors, and you want to go, well, doctor of what? And again, this is not minimizing your knowledge. If you are a doctor, you got a PharmD, doctor of pharmacology, you know a lot about drugs.
Yeah.
But in the same situation, if you're introducing yourself in a clinical environment as the doctor, people are going to assume that you're the physician under care, which is outside of your scope of practice.
Right.
And we can complain and we feel that's not fair or whatever, but there's a reason that we have these scope of practice things. And it isn't because the superstars could probably do whatever. It's because we have to have a minimum level that label safely advertises to the lay person. And if we start screwing up those labels, we're putting in the Wild West environment, so it becomes unsafe. And now everybody has to question everything, which is what I'm saying right now. Question everything, find what their background is. But you're in an emergent situation or an urgent situation, you shouldn't have to do it. People should be doing it. It's incumbent on the clinician to be transparent, so that you're not adding that stress on somebody who's already in a distressful experience.
Yeah, well, you have to be honest with yourself as a professional to recognize psychologically what you might be doing, and recognize, are you doing this for your benefit, or are you doing this for the benefit of the patient in front of you or client in front of you? And like you said, you have to be transparent. We need more of that, and especially in the world of medicine. And I like the fact that you mentioned how context matters. There's a time and a place for, strutting your doctorate that you're so proud of. But when it's in the context of clinical care with patients in a hospital, that it's not appropriate when it confuses the patient. And ultimately, we want to be transparent and make things as clear cut, I think, as possible.
Well, that's a high stakes environment, right? So the context and the labeling has some significant implications behind it. I mean, you can have significant implications if you're taking advice from somebody who says they're a doctor but isn't your physician, or isn't a physician, and may not provide you the information that you need. In a less sensitive manner, though, like if you went to, you went to a mythology convention, you wouldn't want to, I'm Dr. So-and-so, and they're all maybe PhDs in mythology like this person was. If you introduce yourself as a doctor there, you very quickly should say, I'm a physician, or I'm this or whatever, so that you're not in that context, people mistaking you as a doctor of mythology, because you're not, and you would be misleading those people. Now, granted, again, the context, that contextual environment is probably less high stakes than, say, in the middle of a hospital. But if someone wants to learn about Zeus and you want to make sure they're getting the best information, then it's behooving on you as the individual, be very transparent on your background.
Yeah. Well, if I was to try to confuse people around PhDs in mythology, it'd be very obvious very quickly that I am not at that level, because I wouldn't know very much. But I guess in response to this conversation, and in a way that's empowering for those listening, is that if you are in a medical setting, in a healthcare setting, and you're confused by the person that's taking care of you, or what their specialization is, or what kind of things they take care of, and what their focus is, there's no reason people should feel afraid or hesitant in asking the person before them. And it's important for that particular professional to be able to explain what their specialization is, or what their role is for helping them. Any thoughts on that?
Yeah, I think unfortunately it has come to the point where if someone introduces themselves as a doctor, then it is not impolite to say doctor of what.
Yep.
And in particularly where it has you or your loved one's health involved, then you have the right to know what they're a doctor of. And from a practitioner standpoint, you need to be confident in whatever your background is, so that you can say it clearly, so you can and be proud of whatever it is you did. And if you're not, that's not the patient's problem.
Right.
That's not something that they're supposed to deal with. That's something up to you to either address in some way. But from a clinical standpoint, if you are ever in a health-related encounter, wherever it may be, and someone introduces themselves as a doctor, at this point in time, you should say, well, you're a doctor of what? And that could be, I'm a doctor, I'm a physician, but I specialize in cardiology, right? That would have important implications. I'm a physician. I'm an anesthesiologist. That's my specialty, my background. I'm a pharmacist, but I'm a doctor in pharmacology, which means I'm very well aware of the side effects of these medications. I have a doctorate in nursing practice, which means that I did extra training on nursing related issues when it comes to blah, 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 blah. But there's no one should argue that.
Yeah.
I mean, really, there is no reason for anyone to argue against being transparent of what their background is. And the only people who would have to fear that, and who would be resistant to being fully transparent with their background, are the people who have something to hide.
Yeah.
And so anyway, I think that's something for all of us to kind of recognize when you're going. And unfortunately, if you're in an acute situation, things are going crazy, it just adds another layer of stress that you shouldn't have.
And I think ego, insecurity, and perception of status, those inevitably are part of the human psyche at times, that I think some people, it will direct their behavior and how they present themselves. But like you said, that's not for patients to, when you're being transparent and just say it like it is and what you are, that I agree that patients shouldn't have to worry about that. They got enough to worry about.
It's not the patient's problem, so don't make it theirs.
Yeah.
And when it comes to, the psyche, I understand that everybody's looking at status, right? We all are comparing ourselves and comparing and contrasting to this person who's better in that. Anybody who says that they don't, that's totally not true. It's human nature, right?
Yeah.
It's just how we do these things.
Yeah.
But realistically, rather than tearing other people down, you should probably be building yourself up if there is some sort of reason or concern in that regard, rather than trying to muddy the waters in any way, shape, or form. And it is. I mean, and I guess we sort of we we have a unique perspective that as physicians, but also as osteopathic physicians, and maybe you don't see it as much, but it's been there. This idea that somehow DOs were inferior or weren't as good or didn't whatever. And there's some truth to it. I mean, if you look at, I haven't looked at this data in a long time, but if you looked at applications into an MD or a DO program, historically MD programs had higher MCAT apps. So they had higher standardized tests. Oftentimes we were younger applicants as compared to DOs. And so, you can look at that first, and then, but what does that mean, right? But as a DO, I'm also very confident in my skills, and I'm confident I did my training, and I'm confident in my knowledge base. And so it's not up to, if there's an MD that questions my credentials as a DO, I am more than happy then to have that conversation, not by saying that they're bad doctors or, we're holistic and MDs are not holistic and we look at the whole body and MDs don't look at the whole body, which is all kind of ridiculous. Everybody cares about the human,
right.
But be very comfortable about what my background in specialty training is, like what it is that I do and what it is I learned, and be very, very, very clear though, that I'm a DO. I'm a physician, but I'm a doctor of osteopathic medicine. And I would just like to see, again, we've kind of reframed this again, that transparency I think is very, very important. And then if you are coming from this perceived lower status, then make sure that you are addressing those issues so that you can build yourself up and you're confident to it, rather than trying to, tear the other person down or tear down the institution and say, well, they just, doctors are all bad. Well, that's going to create some big problems if for some reason everybody's a doctor now, or doctors, because they're doctors, are somehow not caring healthcare clinicians, which is sometimes put forth too.
Yeah. Well, it's because you brought that up. I just pulled up a quick reference at medschooltutors.com. If you guys want to look at that, it's just one source of someone who's found some data. But they said, are there differences in MCAT scores, which is, what medical students take these tests. But there's been some changes lately for MDs and DOs on these testings. But it said with recent changes in MCAT scoring, there's not an abundance of data on new MCAT scores for MD versus DO. Older studies with the prior MCAT scoring system had MDs with average higher scores than DOs. It's important to realize that individuals in both fields can do extremely well with the right prep. They're going and talking about it. But then they talk about the mean score. The mean MCAT score for applicants to osteopathic schools in 2018 was 25.62, which was the old MCAT, and 503.83 for the new MCAT. And for allopathic, which is the MD programs, the mean score was 511.2. The mean MCAT for accepted applicants to osteopathic programs was 503. So it's really, really close comparatively to the past. I think it's been kind of approaching each other over the last 10 to 20 years from those numbers and from other numbers I've seen. But there was definitely, I think, the numbers you had seen, I've seen that there was some differences. But again, people that score, really well on MCATs or any testing doesn't mean clinically they are effective. And it really is a matter of taking those types of tests.
The number one criteria for how good a clinician is what their clinical acumen is. That's the number one. But that comes from an experience with the individual, right? So then we have all this other stuff. And so the next step would be like testimonials. Now, this becomes very difficult to do in healthcare, but people that actually who can vouch your experience and clinical acumen. And then the next step after that is you have to actually look at the outcomes data of the people. And the next step after that, then you have to, what I'm saying is that the education and the standardized tests and all this stuff keep going lower and lower and lower and lower on the hierarchy. They're required at some point because we to make a decision, we need information. And in a situation with limited information, just like you want to know what the clinical background is, whoever it is, there is some difference for some of this stuff. There's exceptions for sure. I knew a guy that when in anesthesia, who was one of the best, he was in the class ahead of mine. And he was a fantastic resident, couldn't pass his orals.
Yes.
Which I just found shocking. I couldn't get it. I'm like, and I would watch it. And I'm like, what do you do? we've had discussions in the OR. You know this stuff. What are you doing?
Yeah.
Like,
Yeah.
because we had the mocks, right? You would do mock orals and you just watch them, and then I'm just like, I just don't understand how you open your mouth and it's not coming out like you would talk, like you would normally talk. And then there are people that can't pass the test, but there are also people who can't pass their orals and can't pass their writtens that you would not want to touch you. Right. So there is a minimal, we're using that as an imperfect system when we can't get experiential data from every individual out there.
Yeah. Well, it's just like a lot of complex phenomenon that occur.
There's always lots of different inputs into a complex process, and you have to look at all of them in order to see what emerges from it.
And how stress impacts the whole system and the capacity to even think clearly when you're in the midst of those testing procedures.
Well, in different stressful environments, right? Because here's the other thing. The resident I'm thinking of was awesome, and people are crashing and blood's everywhere in the OR, and this guy was just fantastic. But then you get him on front of a stage trying to do a mock orals with people he knows, and it's just like, what did you just say? Why did that even come out of your mouth? That makes no sense. All right, so I guess this is it was supposed to be a short episode, but a long episode to basically tell if you're in an environment with you or your loved one, and it comes down to making healthcare decisions. And the environment includes being in an online space. It includes being in the middle of a hospital. It includes being in the middle of a clinic. It includes being anywhere. If someone introduces themselves as a physician and they're using that as a background of status and credibility, it is up to you. And more importantly, it is your right to say doctor of what, and to get a clear, transparent response to that question.
Exactly. That sounds great. Great advice. I'm not going to say the same thing because I just said the same thing.
Again, this is the end. So we're now.
Yes. Hey.
Thank you all very much for joining us for another episode of the Paindora Podcast. Again, we're not trying to upset. We're not trying to create turf wars in any way, shape, or form. But what we are trying to do is advocate for transparency. So if you're already in a stressful environment, contextual environment, again, whether you're seeking information, that you can get that information clearly. And if you can't find that information clearly about who is providing you that information, that should be a little bit of a red flag for you. And if it takes you 3, 4, 5, 6 different Google steps or searches to figure out what they're a doctor of, to me, at least, that would influence a lot of my decisions when it comes to whoever that clinician is, or if they're even a clinician, or what the advice recommendations that they're trying to give me are.
Absolutely. So. Well, and until next time, this is the Paindora Podcast, Dr. Melissa Cady and Dr. Kevin Cuccaro. And since this is the episode about doctor, we are both anesthesiologists or anesthesiology trained and also had pain fellowships. And we're here to just spread a little bit of knowledge and inspiration and a little bit of perhaps motivation to look into some of these health topics and challenges in life. And sometimes we talk a lot about pain too.
Because it's so fascinating, folks.
We're fascinated.
We're fascinating, and it is great stuff to talk about. Anyway, everybody out there, till next time, stay well.
Bye-bye.